Hello and welcome to the Alabama Public Health Training Network. Thank you for joining us today for our program Patient First and Plan First Coding Update. This training will provide an update on coding procedures for the Patient First and Plan First programs. In an effort to control program costs, more specific directions will be provided on how to code time when patients present with Medicaid. If you have a question about anything being discussed today, please call or email during our broadcast. The phone number and email address are on your screen now and will appear again later in the program. Also, handouts are available online and a link to the post test in LCMS will be posted after the program. You'll need to register for this program in order to access those materials. This program will also be posted on demand if you have questions in the future and would like to review any of the material at a later date. I'm Meredith Adams, Director of Social Work for the Bureau of Family Health Services, and with me today is Renee Carpenter, our State Social Work Director.
Good morning, and thank you all for joining us again. It's been almost a year since we've done this, and you all have made so many wonderful changes, and you have affected the cost in a positive manner. Our costs are down, so I want to commend everyone for that. One thing that we are looking at is as we go through and check everyone's coding each month, what we've realized is that a lot of you aren't giving yourselves credit for the work you're doing, and that's what this is about. We want to make sure that you get credit for all of the work that you're doing. So our objectives today are that participants will understand how their coding affects the billing process. You'll be able to recognize the most common errors associated with SSR coding and how to avoid them, and also understand how SSR coding impacts billable time and productive time. So what is productive time? What is billable time? I know you hear that a lot because that's something that we talk about a lot, especially around budget time. The average employee codes about 20% of their time to leave. That's annual leave, sick leave, holidays, breaks, all of that kind of thing. So that means that about 80% of the average employee's time should be what we are calling productive. So what is productive time? Productive time may be time spent on an activity that benefits the agency, but not necessarily a specific patient. Marketing, that's one of the requirements of the Plan First program. Marketing is very productive, but it's not a billable service in and of itself. Cultivating resources, reading protocol, attending trainings and meetings on behalf of ADPH. All of these things benefit the department, not necessarily one specific patient. Productive time is also time that's spent working with a specific patient, but the time can't be billed. For example, if a patient is in the hospital, we can't bill for that time. Working with maternity referrals to market Plan First. That's something that's very productive, but again, we can't bill Medicaid directly for that time. Also, patients who are not eligible for Medicaid, and you're going to hear me say a lot about eligibility. If a patient isn't eligible, then that means that they make too much money or there's some other reason why they don't qualify for a specific Medicaid program. So how is productive time coded? Well, there are 4 ways you can code productive time. One is to use the QMB code. This is what we use for marketing purposes. When you're working maternity referrals, those referrals that you get from the maternity waiver workers on women who have delivered, and you contact them to let them know about family planning services, that's time that is considered marketing. Health fairs would also be considered marketing. This is, and I know it's probably very difficult for you to see because the writing is so small, but I'm sure you're really familiar with what the SSR looks like. The red arrow is pointing to the QMB code, and again, this is used for marketing. There's a little bit of a change for some of you, but we really want this to only be used for marketing. The blue arrow is pointing to the notes section, and this is where it's critical that you let us know what it is that you're doing that corresponds to that marketing code. A second way that you can code productive time is to code to DPH. That's time that's related to a specific program or cost center as long as it is program specific. So training For example, all training gets coded to the 92 code. Reading Plan First protocol, if it's Plan First specific, then we code it to Plan First. That's 15. Many of you are attending meetings with the RCOs or health homes. Those meetings can be coded to 27 or 39. Again, the red arrow is pointing to where the DPH is located, and the blue arrow is for the notes section. A third way to code productive time is to code DPH with the patient's name. For example, time spent trying to contact a patient who has Plan First Medicaid but who has not had an annual risk assessment. You can't code that to Plan First directly to the patient's name because there hasn't been a risk assessment coded into the system. That's going to be a DPH. Like we said before, patients who are hospitalized, we're not allowed to case manage those patients. So even though you may spend time assisting them while they're in the hospital, especially with some discharge planning, that's not something we can bill for. So we code it to the patient's name and put the DPH there. Now there is an edit in ACORN that prevents a DPH 15.4 with the patient's name if there is a 15.5 in the system. The reason for that is because once a patient has been coded or has been risk assessed as low risk, we don't do anything else with that patient until we re-risk assess them. So that's why that code is there.
And I like your example here because this actually came up in training when we had the last Plan First training. When a patient is on Patient First and they flip to Plan First, you're required to do a new risk assessment, which means you can't bill to that patient until that risk assessment is on file. So that came up because in Patient First, let's say that they need an appointment reminder for depot. Well, we can't bill that time because they flipped over to Plan First and we don't have that risk assessment on file yet. So it's important to get that coding to the risk assessment in the system before we can bill to that patient. So I think that she gave an excellent example there of when to use that DPH.
Again, there you see the red arrows are pointing to the DPH with the patient's name. And also the blue arrow, which is indicating here that the patient was hospitalized. So that explains why this patient could not be billed directly to. And the fourth way that we can code productive time is to use the DPH with or without a patient's name if we're using the indigent codes. A lot of you are using the 30 and the 70, not so many are using the 20, and I don't know if maybe you're not sure what the 20 is for. But the 20 is a family planning code for indigent patients. Maybe it's a Blue Cross patient who needs something. Maybe it is a dual eligible. But for whatever reason, they have some need, they're coming in for family planning services, but we cannot bill for them. That would be a 20.
Maybe they took a pregnancy test when they came in.
And that happens a lot, and it's positive.
Exactly. So we can't bill to Plan First when they're pregnant. So that's one reason that we would use the 20 as well.
And this is a reminder here, a billable case must be closed prior to coding to the indigent code. So, for example, if you're coding to EPSDT and the patient becomes eligible for Blue Cross, you have to close out that 31. You have to bill a 31.7 to the patient before you can pick up with the 70 or the 30, depending on their age. Again, this is another example of an SSR. So how is billable time calculated? Well, it's recommended that billable time account for about 80% of productive time of an employee. So the formula for calculating the expectations of a full-time worker who is working 100% in billable programs is to look at the annual hours. We take 80% of those annual hours, that's your productive time. Then we take 80% of productive time, that's billable time. At the end of every month, Bill will send out an email letting you know how many hours there were to be coded on your SSRs during the month. If you take 80% of that number, that gives you an approximation of how much productive time you should have. and then 80% of that tells you about how many billable hours. It's not an exact science, it's just an estimate. So for example, a month that has 22 paid days, this may include holidays, but if there are 22 paid days, then you multiply 22 times 8 hours per day, 476 total hours. 80% of 176 is 140.8. So that's an estimate of what we would expect as far as productive hours go. 80% of the productive hours is 112.8 billable hours in this case. And that's where we get the average of 113 billable hours per month as the goal for every full-time worker for billable time. This is the number that gets plugged into the budget each year. Now, as far as billable time, there's only one way to code billable time, and that's coding directly to a patient who is eligible or who appears to be eligible for one of the ADPH case management programs. So over the past year, what we have seen drastic changes in the number of employees who are definitely completing SSRs on a daily basis, and that is fantastic. Most of you are coding to COM and DPH utilizing your notes section on the SSR. That's wonderful. We're able to give you productive credit for that. Most employees are utilizing the indigent codes accurately to reflect time spent with a non-eligible patient. Because of that, our costs have gone down over the past year. What you've done, what you are doing is working. Also, one of the things that I have seen quite a bit of is you need to make sure that general staff meetings or general office time gets coded to the 94, not to 15.4, 31.4, not to a billable code. And what I see most often is the end of the month reports, for example, a mileage form that you're working on, going through and reviewing your SSRs. Those are things that are really general office. It's just part of doing business every day. So those should be coded to the 90. But I do want to point out that what you've been doing this year has been successful. There are a few areas of opportunity, and again, not to say that anybody's doing anything wrong, but you're not giving yourself credit. So these are just a few ideas of ways that you can make some minor changes to make sure that you're getting all of the credit for all of the work that you're doing. One area is when a patient switches programs, always close out the previous program before coding to the current program. And I think where we see this more often, correct me if I'm wrong, but I think where we see this the most is our teenagers who age out of EPSDT case management. They turn 19, they flip to Plan First. We've got to make sure that we enter a 31.7 so that we close out that program before we can code time to risk assess them under Plan First. Another example is if a patient has been receiving high-risk intensive case management but then flips to Patient First Adults, then we've got to close out that Plan First case using the patient's name, the 15.7, then we can bill under the patient's name and the 21.4. Now, one thing to remember in this example is you've got to follow Patient First protocol. So you've got to make sure to do a referral form, do a risk assessment update, and make a progress note to explain why you're switching programs.
But they can go ahead and start billing directly to that patient, because when we flip from Plan First to Patient First, you do not have to do that new risk assessment. You just have to update the Plan First risk assessment and change the program. So we can go ahead and bill that time to the patient. Good point.
And a third example is if a patient's been receiving services under Patient First Adults, then becomes eligible for QMB, which is Medicare, a Medicare program, then you have to close out Patient First Adults by coding to the patient 21.7, and then begin coding using the patient's name and a 70, because this patient is not eligible for a Medicaid case management program. Now, a second way that you can increase your billing and your productivity time is to never close out a case because a patient changed from Plan First to Patient First without opening it in a Patient First case management. unless that patient refuses services. And I've seen this happen a few times, and I think it's because we have folks who are specialized. Maybe you are a plan first worker and somebody else does the patient first. But as long as you're certified, then you can go ahead and continue the billing. A third way is to never code DPH time spent working with a patient who has applied for Medicaid if that service is otherwise a billable service. The reason is that many, many times we have DPH time that we've lost. The patient later becomes eligible. That eligibility retros back to the date of the application, and all of the time spent with the patient that day was billable to that patient and would have paid had the worker not coded it to DPH. And I know there's this sense out there that a denial is a bad thing. That's not necessarily true. Denials are easier to work. If you DPH time, that time's lost. We're never going to be able to rebill it. If we code to a patient and that particular service was denied because the patient wasn't on Medicaid at the time of the service, it will bounce, or we call bouncing, for 3 months, where it pings at Medicaid and it's looking for that eligibility. If 2 months down the road the patient becomes eligible, then that particular service will go through and it will pay. But if you DPH that time, it's lost. A fourth way that you can increase your time is never DPH time spent working with a patient who has temporarily lost Medicaid if they appear to remain eligible. This seems to happen the most around the time of certification. A lot of folks don't get their certification paperwork back in time, or maybe the worker at Medicaid is on FMLA and so she gets a little bit behind. These things happen. That's a part of business. But don't DPH the time if it looks like that patient may get back on Medicaid. Go ahead and bill it to the patient. If it denies, that's fine. But at least bill it to the patient. That way you get credit for that time. A fifth way is never code general office activities to a particular program. If it's, again, like I said, if you're doing a travel form or something like that, a general staff meeting, those go to the general code, and make a note about what it is. But if what you're doing is program specific, then go ahead and code it to that program. A sixth way is to never follow up on a Plan First patient who is risk assessed as low risk. That actually violates policy or protocol.
Yes.
If you are needing to send out appointment reminders, for example, to a patient who was low risk, then that patient really wasn't low risk. That patient needed to be high risk minimal. Never DPH time spent providing follow-up services on patients just because their Medicaid status is pending. Again, that DPH time gets lost. So we need to go ahead and bill it directly to the patient. If it denies, that's fine. We'll work the denial. But at least go ahead and code that time to the patient. And never DPH time spent documenting on a Plan First patient who refused services. And by that I mean make sure that you're doing all of your work, including your documentation, before you put the 7 into the SSR. So for example, a high-risk intensive patient, you would have a 15-6, then a 15-1 where you're recruiting. If the patient refuses, that's fine. The next code is a 15-4. That's time that you spend documenting all of your work. And the last thing you would code is the 15-7. That way you're getting credit for all of the work that you've done. The 9th way is never DPH time to Plan First for time spent working with a woman who has a positive pregnancy test. Plan First is for pregnancy prevention. If she's pregnant, we can't prevent that. So it's time to go ahead and code all of that time to the indigent code. We know a lot of women don't intend to become pregnant, and they're very upset. We see a lot of that. And they also need referrals to WIC. They need referrals to the maternity program. So that time that's spent with those women, go ahead and code it to the patient's name and code it to a 20. That way you get credit for it as productive time. And this 10th one, this is the last one because this is the most confusing. but never bill time to DPH for time spent working with a patient who has flipped back and forth between patient first and plan first if she currently has a plan first risk assessment in the system and she currently has plan first Medicaid. So this is January, so everybody is eligible for a new risk assessment now because those are based on calendar years. So if you do a risk assessment now, and then say around March or April when you check eligibility, you find that she's flipped to patient first. Then you follow the patient first protocol. But then long about August, September, you discover she has flipped back to plan first. She has a risk assessment in the system for this calendar year. That means that that time that you spend with her from this point forward, from August forward, that's billable time. You don't have to risk assess her. All you have to do is ask your supervisor to contact Jennifer McNeil and have that 7 removed from the system. That opens the door for billing and lets you go ahead and continue billing for those services. And again, that gets your billable time up and it gets your productive time up. Meredith, there's some protocol changes that go on with this.
Yes, and right before we got down here to do the satellite, I sent out the Patient First Protocol updates. So those are available for you on the document library. There's a link in the email that I sent out. And some of this is just reiterating what Renee has already gone over. We wanted protocol to match what we were talking about with coding. So some patients and families meet all the criteria for Medicaid eligibility but have failed to either apply for Medicaid or recertify at their annual review. In these situations, the care coordinator should encourage and assist families in activating their Medicaid coverage. You'll need to code time to the patient with the appropriate billable service area and not the indigent code or the non-bill code. The other thing that I've added to protocol is to please complete a new referral form each year on your family planning patients that are patient first eligible. So when you sit down to do that new risk assessment each year, you'll want to go ahead and complete a new referral form on that patient as well so that we can get credit for that referral. So here's an example. You see your patient initially in, let's say, 2012, because we have some patients that are doing a great job of coming in every year for their annual exam, and they continue to get their birth control method at the health department, and they are Johnny on the spot and doing exactly what they need to do. So they've been consistent with their family planning services. So when the patient comes in this year in 2016 for their annual reassessment, because we have to complete a new psychosocial assessment every year on our patient first patients, go ahead and submit a new referral form in ACORN. That way I can collect that data and we can track those referrals.
So now's the time. If you have any questions, please go ahead and call. I know this is confusing. I know it feels like we change our mind every time you turn around. And I guess we do. But what we are discovering is, we are moving into a new world. And we are, for the last 25 plus years, we have billed our program, our time, we've billed it on time. Now we're going to move into the RCO world where we will be getting paid a capitated rate. So the things that we have done for 25 years don't necessarily apply in this new world. So that's why there's so many things changing. And when we make one tiny change, we affect the Office of Program Integrity, we affect IT, we affect revenue recovery, we affect protocol,
we affect
finance, we affect costs, we affect cost accounting. So it's not as simple as making one line change in a protocol manual. There's a lot of things that affect a lot of other things. There's a domino effect out there. And we're just learning how to really code our time so that it benefits the agency the most. We're not asking anybody, and please hear me, we're not asking anybody to increase your billable time.
No
fraud. We're not asking for that. What we want you to do is to get credit for what you're already doing.
And make sure that you're coding accurately. The amount of time that an activity takes, you need to code that time accurately. I say in training, if you bill more than 15 minutes for an unsuccessful phone call, that's excessive. So we want to watch that time. And sometimes our decisions on what bills excessively and Medicaid's opinion on what looks excessive are two different things. So I've had calls from directors saying, but Meredith, do you realize what goes into that unsuccessful phone call? Yes, I do understand all of the steps that you have to go through. You've got to put it in Acorn. And some of you have an extra EHS system. I know down in Mobile, that's a big concern, that they have to get that information into their electronic health record as well. That takes time. It really, really does. But one of the things that we're trying to do is we're trying to align ourselves to be a productive resource for the RCOs when they come into play. So these changes that we're making, it's not because we're bored. We really have a lot to do, just like you do. And we don't like making changes to confuse you. It's just we're trying to align the health department to be as successful as possible when the RCOs stand up in about 9 months. So we're trying to make changes now to try to get us ready to go for when those RCOs do stand up. So that's one reason why we continue to make changes. And part of the quality improvement process is to assess what you're doing and see if there's ways that you can improve and become more efficient. We think you're doing what you need to do. We just think you might be missing the credit that you deserve for it. So that's why we wanted to go over this today, because we think there's some areas where you can get more credit for what you're already doing. So we've still got plenty of time. We still have about 30 more minutes, but if you have questions, please do not hesitate to call us or email us. We are right here, ready to go. I'll even open it up to entertain other questions that are not specifically related to coding. So if you have any other questions, I'm happy to take those as well.
Do we have any questions in the audience?
Well, we actually have a call from Calhoun County. So we will take that call from Calhoun County. So go ahead, caller.
Hey, this is Haley in Calhoun, and I actually have several questions.
Okay. Well, Haley, let's take those one at a time.
Okay. Perfect. Okay. The first one here in Calhoun, all the care coordinators here, we screen every single female that comes in, whether it be an STD who's had a tubal, family planners, anybody. Should we be spreading out the time for each patient that we get up to see and screen?
Okay, let me back up, and I want to make sure I understand what you mean when you say screen. Tell me what you mean.
Okay. We screen everybody that comes in for Medicaid. The nurses call us for every single female that comes in. So that way we're not missing any that may qualify for Medicaid.
Okay, that was my question. You just answered my question.
Okay.
So you're checking to see if they are eligible.
Yes.
For Medicaid.
Okay.
Yes. And some of them, are not. They may be pregnant. They may just be here for STD, and they've had, a tubal or something like that. But should we be individualizing all these times that we get up?
How are you doing it now? Let me ask that question.
Well, at the end of the day, we just kind of put it all into our, we have been told in the past, just do it all to 90. Because we do get up often here.
Right.
And we also schedule all the implanon and IUDs, no matter what kind of insurance they have, and we get all the phone calls for those.
All right, so you're also scheduling appointments.
Yes, ma'am.
Okay. All right, let's back up and let's work on first the patients that you're screening for Medicaid.
Okay.
When you screen a patient for Medicaid and they appear that they're eligible,
yes,
dependent upon what their needs are, I would code that to that program and to the patient specifically.
Okay. And don't be afraid of coding to the wrong program, because I know when they fill out the application, some will get patient first and some will get plan first.
Right.
It's okay if it's the wrong code. It will deny, we'll go back and work the denial, and we'll get it into the right code. So don't be afraid of a denial.
But if you screen them and you want to code them to plan first, you're going to have that risk assessment on file in order to code that time. So if they're there for, if they're there for an STD and they appear plan first eligible and they've applied for plan first, I'd go ahead and do that risk assessment with that patient. And
we normally do. We normally do that.
That's great. Great. Yeah.
mainly for the ones, because we, like I said, we see everybody, so we're busy. Just the ones that I guess that we can't bill for, but that we're actually getting up to go check on, what should we do for that?
Okay, and again, if they appear Medicaid eligible and they've applied, I want you to code that to the patient and to the program that they appear eligible for, with the caveat, if it's Plan First, you got to do a risk assessment.
Okay.
Okay, so those patients that are not eligible for Medicaid that you go to check on,
I would say indigent codes. That's where you code to the 20, the 30, or the 70.
We have a question in the audience. Would you code that to the indigent code in COM? I think that would. If it's I don't think marketing is primarily for Plan First when you have a maternity patient, or you're doing a health fair, or you're talking to a doctor to try to recruit patients in for that. So I don't think it would go to 15 COM. I like the indigent code.
Okay.
And I think I'm going to call it DPH.
Okay.
Mm-hmm.
Yeah, and not COM.
Should we, if we do that, should we does there have to be a note in the chart to go with that, or can we just put a note at the bottom of the SSR?
That's going to depend on if they have a chart.
Okay.
Because a lot of them may not even have a chart. If they don't have a chart, put it in the note.
Okay.
If they have a chart, I would make a note in the chart.
Okay.
We have a comment from the audience.
I don't think COM's available for 20 anyway, so.
Okay. So COM is not an option for Service Area 20. Okay, so did we answer your
first question?
Your screening question?
Yes.
Okay. Do you have another question?
One more thing on that.
Yes.
So we should have a little bit of time for almost every person that we go and speak to, even if they're not Medicaid eligible.
Now, remember when Renee went over how the formula works? What that basically amounts to is you have 2 hours every day that we are not expecting you to bill directly to a patient.
Okay.
So you've got 2 whole hours every day where you can pick those patients up, and maybe you'll get lucky and get somebody that's eligible.
Okay. And then I just wanted to clarify one thing.
Okay.
If we have a patient that's open in our caseload, and while we're working on them, the Medicaid has become inactive. Mm-hmm. Well, we've not been able to get in touch with them, and we don't, they appear Medicaid eligible, but we don't know when we will see them again. Should we code that to 15-4 DPH to the patient?
I'm going to defer that to Jennifer.
Okay.
What would be the best way to do that? She's in our audience, so.
Okay.
They should still code to the patient and the program in the hopes that the patient is going to complete their paperwork, because we don't know, if we're not in contact, we don't know, the patient may be seeking Medicaid eligibility through other means. So
okay, good point. You probably couldn't hear her, but what she was saying is that if you're not in contact with the patient, we don't really know whether the patient is getting all of their paperwork together to get back on Medicaid. So go ahead and code that directly to the patient.
Okay. That was all my questions.
Okay. Thank you, Haley.
Thank you.
Okay. Oh, okay. Do we have any questions in the audience? No? Okay. And we do not have any callers at the present time. We have no emails. Again, we have time, so if you have questions, please do not hesitate to call or email us. We are still here. We are happy to entertain those at any time.
The time that you're spending watching this, that goes to 92. So this is training. So make sure that you code it to a 92. That way you get credit for it as far as productive time. So if you have questions later as you're going along, please don't hesitate to get in touch with your manager or director, and then let them forward that on to us so that we can keep a list. What I'll do is I will post the answers to those questions in the document library under the social work division. So that way you'll have those answers, because we can't necessarily answer all of the questions. We have to go through a lot of other people to find out how the answer would affect their part in this whole system. So that is where we will put the answers. If you have any questions, please don't hesitate to get those to us.
And we do have another call coming in. So one thing I did want to mention as well, if managers and directors, if you have new staff that have come on board, it might be beneficial to them to view our coding, our SSR coding training that we did in February of 2015 before they view this training on demand. That might be a natural progression for them because we kind of tag teamed on things that we discussed last February as well. So it might be good to, and it could be good that staff review that along with this training as well to make sure that we're all on the same page about coding. Okay, we have a call that has come in, so you can go ahead, caller.
Hey, Meredith, this is Meg.
Hey, Meg.
And Renee.
Hey.
Renee, would you talk about the billable time and per month and how it equates to the year, and talk a little bit about how it equates to the budget, and just give a little information about that?
Sure. The time, the 113 billable hours is an average. Some months it'll be as much as 118, sometimes it may be 104. It depends on how long or how short that month is. What we look at is 1,348 roughly hours per year. So if you are taking a vacation for a week, obviously you probably won't get your billable time in for that month, but it's actually spread out over the entire year. If you have a bad month, we don't look at just one month. We're trying to get that number, the 1348, 1350, for an annual year. That's what gets programmed into the budget for a full-time worker. And because of that, once a month, Meredith and I sit in a finance meeting and we look at where we are statewide. Some counties may be meeting their budget, they may be going over, some may be under. For example, this time of year, a lot of times in the north, folks are not able to meet all of those billable hours because there's snow and ice and your health departments get closed. There's always things that will happen, so we're not looking at exactly 113 hours for a month. We are looking at an average or a cumulative total, I guess is the best way to put it. And that's how it goes into the budget. Did that answer your question, Meg?
It did. And so would you say that if a worker, say, wants to take vacation in July, they want to take a week off, they should try to bill as much time prior to that week off, or
oh, absolutely.
in other words, plan for
Exactly.
the whole year.
Exactly. That's exactly right. And don't forget, for your Plan First workers, it's a new calendar year. You can go ahead and do more risk assessments now, which then makes them eligible for billing for another full year. So even if you just did one in December, I know it may not be the best thing to do, but you can do that. You can go ahead and do another calendar year. Medicaid is looking for that. They're looking for a risk assessment during a calendar year. They're not paying attention to whether it was done 2 months apart or 11 months apart.
Meg, did that answer?
It does, and thanks so much.
Thanks, Meg. We've had several email questions to come in. So our first one is, if we as ADPH employees are attending meetings outside the health department as ADPH representatives, do we code that time to COM?
Yes. The answer is yes. We have always coded that to COM because you're representing ADPH in a non-ADPH setting.
Okay. Our next question, if you're working with a coin patient and they come into the clinic and you assess them as usual, not realizing they are on your coin caseload, how do you code for any of this? The patient has full Medicaid. So I think that my question would be, what were you assessing them for? I'm going to read into this and I'm going to make the guess that you were doing a psychosocial assessment with the patient. So if it's COIN, let's go over what a COIN referral is for. COIN is for an adverse pregnancy outcome. Those referrals are coming from our maternity care providers, and this patient has had some type of an adverse pregnancy outcome, either with the current pregnancy or a previous pregnancy. And our role is to try to get that patient in with a PMP. And we also want to ensure that the infant gets in with their PMP as well. So that's what we're charged with a COIN patient. If they come in and they're in the health department, you see them face to face and you do a psychosocial with them, I'm okay with that still being coded to the COIN service areas, because that referral came in for COIN, and you can follow up with your COIN reasons with the patient as well. Now, if you do a psychosocial assessment with that patient and you determine that there are other issues involved, then once you've completed your COIN reasons, referral reasons, you could then switch over and bill that patient to patient first, if they are patient first eligible. And I'm hoping that answered that question. If it did not, go ahead and re-email me, and I'll see if I can clarify better if I did not already. So we have a question about rebills from October. Should we submit corrections from the October SSRs sent to the area from Renee where ineligible patients were DPH/COM'd because of billed to patient? And I'm happy to read that again.
And I'm going to say, no, I think I understand what they're talking about. You're wondering if you need to make these corrections, and I'm looking at Jennifer, but I'm thinking no. Is that, yeah, okay, that is correct, no. So at this point, the things that we've talked about today, really just start with January. What's done is done. We don't really need to take time out of your schedule to go back and make those changes. Just start with January and make sure that those changes are made prior to the download.
Okay. All right. I don't see that any more emails have come in. We are still here for a few more minutes. If you have any questions, please feel free to call or email us. We are happy to take those questions.
I want to go back to something with the COIN question, because
okay.
I remember there was a statement in there, I think, that if you don't know that this is a COIN referral, so it sounds like, what if the patient has already had a risk assessment under patient first, I'm assuming for family planning purposes, and then later on you get a referral that it's COIN. Do you redo the psychosocial? How do you handle that?
That psychosocial should already be on file,
okay.
I would think. Now, a referral form should be completed for the family planning referral so that we can count that referral number as well. So the patient could have 2 referral forms in ACORN, because we'll have one for COIN and we'll have one for family planning. So that's a possibility as well.
Would you then go ahead and update your psychosocial?
Okay, I'm sorry. I was being told about a call, so I didn't hear your question. So go ahead, Melissa, ask your question.
Would you then go in and update your psychosocial assessment if you had one on file?
Well, your psychosocial would have been done for patient first. So I don't think that you would have to do anything with that. Yeah. We have a call from Marengo County, so go ahead, caller.
Hey, Meredith. Hey, Renee. This is Natalie.
Hey, Natalie.
I just wanted to clarify, just so that I make sure that I'm understanding correctly. Whenever we use the indigent codes, the 20, the 30, and the 7, because the patient does not appear to be eligible for any of our programs, are y'all saying that we always, even if it's directly to a patient and we're going to document in the chart, that we still use the DPH code with the patient's name?
No, you don't have to. No, you can code it directly to the patient. You don't have to do the DPH. It's not going to bill either way.
Okay.
Now, if you don't have a patient's name because the patient doesn't have a chart, or it was just a phone call, maybe they didn't give you the name, then in that case it would be better to just do the DPH and then put whatever information you have down in the notes section.
Okay.
Yeah.
Okay.
But the time's going to get captured the same regardless.
Okay. And then my second question was, like the previous caller, we see almost all of the patients in a lot of our counties that come through the clinic, even if it's kind of for us to make sure that we're not missing anybody.
Right.
And it may even be that they go in and schedule an appointment real quick for them because they were sitting there and it was the last person they saw, so they went ahead and scheduled the appointment. Were you saying even in those cases that we need to go ahead and put a note in ACORN that we did that for that person, or do we need to spend our time doing that because they may have another person waiting on them, and then they're having to go back and try to put all that documentation into Acorn, or even put the patient actually into Acorn.
I'm going to see if if I'm understanding you correctly. So they may be just making an appointment for a person that they didn't do any other services for. Is that correct?
Correct. Or even a patient that's all kids or Blue Cross, and they're just determining, hey, I don't actually have to see you unless you're having any trouble with anything, and they let them out the door. It takes all of about 5 minutes, but they did have to get up from their desk, go make sure, then go sit back down, which I know that sounds ridiculous, but it does take up some of your time when you're trying to work on something else.
You do that 6 or 7 times a day, and that's an hour gone right there. And that's what you have hit the nail on the head there, Natalie. That's what we were seeing, is folks doing so much work and yet getting no credit for it. And that's what we're trying to correct here.
Exactly. So would it be, instead of them having to spend an additional 5 or 10 minutes putting that documentation into Acorn, that they did that, could they just bill that to a 20, 30, or 70, and then at the end of the day list those patients' names in the SSR?
That's the easiest way to do it that I can think of.
So then they wouldn't actually, if they didn't really do anything other than that was really substantial work on that patient, then they wouldn't have to put a note into Acorn, as long as they put a note at the bottom of that entry. This is how many patients I saw, here's their names.
Right.
It's in the SSR note, but not in Acorn. Is that okay?
Yes, that's exactly right. As long as they're using that indigent code, it's fine.
20, 30, or 70. In these cases would probably be 20s because they're in the clinic for family planning purposes.
Yes, that's exactly right.
Perfect. Thank you so much.
Thanks.
Thanks, Natalie.
Bye-bye.
We have gotten another email question. Please talk more about closing out cases. We are to close now after 60 days with no contact, but I thought I heard you say be careful about if patient is still eligible or likely eligible. I think that we're talking about Plan First right here, because that's where that protocol change was made within the past few months. So if a patient is still eligible for Plan First, but you've had no contact with them, you'll still want to go ahead and close out that case after the 60 days like protocol prescribes. But if the patient decides to come back in later, then you can always reopen that case. So I hope that that answered that question. If not, feel free to email us with a follow-up. Again, we have a few more minutes. If we have any questions, please feel free to email or call us with those, and we're happy to take a swing at those questions. I hope that today was helpful for you. I hope that this helped to clear some things up. We have gotten another email question. Please clarify the QMB and ADPH cost center. Recently, I received instructions to code to 70, 30, or 20-4 QMB when dealing with a Plan First or Patient First client who is not being followed by care coordination. Please verify how to code for a client with Plan First Medicaid who calls for an appointment, which I set up. Client does not receive CC services. So I think I'm going to make sure I understand the question. So let's say that you low-risked a patient. Maybe they're on Implanon or they got an IUD, and they call in to set up their annual appointment, but they were low risk, so technically you couldn't bill for setting that up. So I'm hoping that I'm understanding that question correctly. So where would we like for you to code that time on a Plan First patient that was, say, low risk, that's calling in to get their annual set up? I think I understand that. Does that make sense to you?
Yes, it does.
All right. So in that situation, they're not eligible for care coordination services because they were low risk. So do you want that DPH to the program or coded to the non-bill codes, which would be, for a Plan First patient, would be a 20.
Right, yeah, it would be the 20. Because they're not eligible for case management.
They're not eligible for case management because they were low risk.
Right, unless there's another problem and you have to do another risk assessment and make them high risk.
They would have to come in, but still that time to set that up, they wouldn't be able to bill that to Plan First.
Right.
So our answer is to code that to the 20. Mm-hmm. Okay?
Right.
And then I think the follow-up to that is if they bill to the, I would just code it to the patient. I wouldn't worry about the COM or the DPH.
No, just to
you
the
just
patient.
code it straight to the patient. So the 20-4 to the patient. And I think Bill told us that you can't DPH in the 20 anyway.
I can't COM.
COM it. I think that's what he said. And we've had another email question to come in. Is it okay to bill for remedy and to bill for patient first for the same patient if being followed for both programs? I have contacted patient on one day for remedy, follow-up, and billed to that program, and then made contact on a different day for birth control follow-up and billed to the patient first program for that contact. Is this correct? Okay. Yes, you can bill to both, and when you say remedy, I think that we're meaning the health home codes. So you can bill to health home on one day and to patient first on the other day. I would want to know if it's possible to combine those services on the same day because it's going to save you some time. That would be a time management issue there where you could combine those services on the same day, and you could split your time between the health home and patient first on the same day, and it'll save you some documentation time and running back and forth and getting that record and having to file and print, and y'all know everything that goes into that. So I would try to combine those services on the same day as much as possible just for your time management purposes. But yes, you can split that billing. That's not a problem. Okay. We still have a couple more minutes. If there are any other questions or emails, we are still here. You are welcome to call us or email us. I do want to remind you that if you are viewing this program on demand, we actually aren't here anymore. So this is Tuesday morning, January the 12th. It is between 9 and 10 a.m. So if it is not between 9 and 10 a.m. on Tuesday, January the 12th, we aren't physically here. So you'll need to email us or call us directly at the numbers listed on the question slide so that we can follow up with those questions after the broadcast date. This program will be available on demand in a couple days. They always tell us it's 2 to 3 days, but I'm telling y'all, video communications is just Johnny on the spot, and I wouldn't be surprised if I hear back tomorrow that it's ready to go. So I'm going to tell you 2 to 3 days, and that's when you can view it on demand as well. If you have follow-up questions, you can always call or email us. And we have another call coming in. We're doing a good job of stretching to give y'all a chance to talk. Okay, we've got a call from Marion County. Go ahead, caller.
Hey, this is Heather in Marion County.
Hey, Heather. I didn't answer your question earlier, did I?
Well, yes, you did.
Okay,
but we
good.
have another question.
Okay.
I just wanted y'all to speak more about when you are coding directly to a patient name and oh, sorry, I think we have a delay. I was watching you on the computer.
Oh.
We're obviously very delayed. But when you were talking earlier, I think the last caller asked about just making, the call in to make an appointment, and y'all used the low risk and maybe making an appointment for her. And you said to just bill it to the patient name, not DPH, no COM. What has to go in ACORN, though? Is that do we have to have something in ACORN in order to have the matching SSR, or does that matter since we're going to do it to the indigent code?
Don't you have to have a CHR number?
Yeah, which means you're going to have a note in the CHR in order to satisfy program integrity. You're exactly right, Heather. Let us talk to program integrity, and this will be one of those questions that we put out on the document library.
Do me a favor, Heather, and go ahead and email us that question so we have it in writing to make sure that we answer it correctly.
Okay.
Thanks,
Will
Heather.
do. Thank you.
Thank you.
Bye-bye.
Sometimes we don't have all the answers and we have to follow up because, like Renee said a minute ago, when we make a change, it's a domino effect, and it affects multiple areas and multiple bureaus throughout the department. So we don't like to get on camera and tell you something and it be wrong. So we do want to follow up with OPI on that and double check to make sure that we're telling you the right thing. So we'll get Heather's question in writing, and we'll do kind of a frequently asked questions section and post that on the document library for you. And in fact, we're having discussion about it in the room right now, trying to get a good answer to that. I'm seeing lots of wheels turning in front of me, so we are working on it and trying to figure that out. Again, if you have any questions, please don't hesitate to call or email us. We have a couple more minutes. We are still here, again, if it's Tuesday, the 12th.
And we all know that those of you who are in the field, you're doing this work every day, you're going to be the ones that come up with these questions. We can't think of them all up here. So if you have a question, if something comes up next week or next month or whatever, email us, and then again, we'll get those answers and put it on the frequently asked questions.
Okay. I don't want to make you just sit here and stare at us. Oh, we've got one coming. We're doing a good job.
That delay.
Yes, of giving it a moment for y'all to, because I know a lot of you have told me in the past what you do is you get together as a group and you sit down, and then once we finish talking, you talk about it. And then you call in with your questions at one time. So we wanted to make sure we gave you plenty of time to get those questions in. So our call is still coming in. We have a call from Montgomery County. So Montgomery County caller, please go ahead with your question.
Yes. I'm calling to find out whether or not the 2 hours is encompassing of your break each day.
The 2 hours, your breaks would be a part of that.
Yes.
Okay.
Mm-hmm.
Yeah, I see what you're saying.
Yeah, it took me a minute too.
Yeah, it takes a second. We got to think. So yes, your 2 hours, that does include your 2 15-minute breaks. Yes.
But again, that is stretched out over an entire year. So don't get hung up on the 2 hours, 6 hours a day kind of thing, because it's really what it boils down to is what has happened over that entire year.
Okay, then. Thank you.
Okay, thank you.
Thanks.
Okay, we are now actually getting short on time. So if you have any questions, go ahead and call those in or email us. And once we are done today, if you have any follow-up questions, please do not hesitate to call or email us. If it's a specific protocol question, you can route that through Sean, and she will take a hand at that. And I think, do you have a question? Oh, we think one might be coming because we have technology in the room, and we're getting texted from the field telling us that there might be something coming in. But if you have questions after the broadcast date, please do not hesitate to call or email us. And all protocol questions, you can route those through Sean, and she'll take a stab at them and then send them on up to me.
And we will add them to the frequently
Yes.
asked questions page.
Thanks, Renee. Good tag team there. Yeah.
And that will be in the social work unit. There's just far fewer things in the social work box than there is in family health services.
Yes.
So it would make it a lot easier to find a frequently asked question that way.
I have one question. In preparation for the EHR, should we not be thinking about documenting everything that comes in?
Sean has brought up a very good point. We are moving towards an EHR, and in those discussions, one thing that is being talked about, and y'all don't, this is not in protocol yet. This is just a heads up for when the EHR comes. When we're talking about coding to those indigent codes or those non-bill codes, there is discussion in the EHR meetings that anytime that you code to that, you will have to put a note into the EHR for everything that you're doing. But that's not here yet. So, but be thinking about that. So you might want to, like Renee mentioned earlier about, I think we're following back up on the note for, with OPI on the notes for the 20. We may just want to start getting in the habit of doing those notes because the days coming kind of quick as to when we will have to put those notes into the EHR because it will be a requirement of the EHR. So that was an excellent point. Thank you, Sean.
But when we have an EHR, we will no longer have to do any filing.
Woohoo!
So that will offset it. There will be no paperwork.
That's a good thing. Got to find those positives. Yeah.
So it sounds like we're adding work when really it's not. It's not adding work at all. It will cut into a lot of the time that you spend pulling out charts.
Okay. All right. Do we have any more questions from the audience? Okay. All right.
All right. Well, thank you so much for joining us today, and we hope that this will make you feel a lot better about what you're doing. Certainly not trying to stress you out anymore. What we're trying to do is make sure that you do get credit for all the work that you're doing. Thank you for all the work that you're doing. It's showing up in our numbers. I promise you it's showing up, and you're doing an excellent job. So thank you, and have a good day.
Thank
Goodbye.
you again. You're doing great. Thanks.